The large intestine represents the final section of our digestive system. Its primary role is to absorb water from the remaining indigestible food matter. It then transmits the useless waste material from the body. Think of it as the body's highly efficient waste processing and water reclamation plant. This organ is crucial for maintaining fluid balance and for the formation and elimination of feces. Understanding its structure and function is fundamental for any aspiring medical or nursing professional. It is a key player in overall gut health and, by extension, systemic well-being. We will delve deep into its anatomy. This substantial organ is strategically located within the abdominal and pelvic cavities. It essentially frames the coils of the small intestine. The large intestine commences at the ileocecal valve, the junction where the ileum, the final part of the small intestine, empties its contents. From this point, it arches superiorly on the right side of the abdomen, then traverses across the abdomen, and finally descends on the left side, before terminating at the anal canal. Its position makes it accessible for various diagnostic procedures and susceptible to involvement in widespread abdominal pathologies. Its course dictates how symptoms of colonic disease might present. In terms of sheer size, the large intestine is quite impressive. It typically measures around 1.5 meters, approximately 5 feet in length. This is considerably shorter than the small intestine, which can be over 6 meters long. However, the large intestine earns its name due to its significantly wider diameter compared to its predecessor in the digestive tract. This larger caliber is essential for its functions of storage and water absorption. There can be some individual variation in length, but the general proportions remain consistent. This length is packed efficiently within the confines of the abdominal cavity. A thorough grasp of the large intestine's location and dimensions is not merely academic. It forms the bedrock of clinical reasoning for a multitude of conditions. Whether you are diagnosing appendicitis, managing inflammatory bowel disease, or screening for colorectal cancer, this anatomical knowledge is indispensable. It allows you to interpret imaging studies accurately. It helps you understand the spread of infection or malignancy. For medical and nursing students, mastering this anatomy is a non-negotiable step towards becoming a competent healthcare provider. Consider this your foundational map for a critical bodily region. The wall of the large intestine, like other parts of the gastrointestinal tract, is composed of 4 main layers. From the inside out, these are the mucosa, submucosa, muscularis externa, and the serosa or adventitia. The mucosa is notable for its lack of villi, which are characteristic of the small intestine. Instead, it has numerous straight tubular crypts of Lieberkühn, rich in goblet cells that secrete mucus. This mucus lubricates the passage of feces and protects the intestinal lining. The submucosa contains blood vessels, lymphatics, and the Meissner's nerve plexus. Understanding these layers is key to understanding function and pathology. Externally, the large intestine exhibits several unique and visible features that distinguish it from the small intestine. Perhaps the most prominent are the Teniae coli. These are 3 distinct narrow bands of longitudinal smooth muscle. They are shorter than the colon itself, which causes the colon to pucker and form sacculations. These bands are not circumferential like the outer longitudinal muscle layer of the small intestine. Instead, they are concentrated, providing powerful directed contractile force. The Teniae coli converge at the base of the appendix, a useful landmark for surgeons. The puckering effect created by the Teniae coli results in the formation of haustra. These are small segmented pouches or sacculations that give the colon its characteristic bunched-up appearance. Haustra are not fixed structures. Their formation and effacement are dynamic, contributing to the mixing and slow propulsion of colonic contents. This segmentation aids in the final stages of water and electrolyte absorption. The presence of haustra is a key visual differentiator between the large and small bowel on radiological images. They play a crucial role in the slow transit time through the colon. Another distinguishing feature found on the surface of the colon are the appendices epiploicae, also known as omental appendices. These are small, fat-filled sacs of peritoneum. They are typically attached in rows along the length of the colon, predominantly along the Teniae coli. Their exact function is not entirely clear, though they may have some protective or immunological roles. Clinically, these small appendages can become inflamed, known as epiploic appendigitis, or undergo torsion, causing localized abdominal pain that can mimic other acute conditions like appendicitis or diverticulitis. Their presence is a hallmark of the colonic serosa. The journey through the large intestine begins at the cecum. This is a blind pouch situated in the right iliac fossa, just inferior to the ileocecal valve. The ileum empties its contents into the cecum through this valve, which prevents backflow. Attached to the posteromedial aspect of the cecum is the vermiform appendix, a narrow, worm-like tube. While often considered vestigial, the appendix is rich in lymphoid tissue and may play a role in gut immunity and repopulating gut flora. However, it is more famously known for appendicitis, a common surgical emergency. The cecum itself acts as a reservoir for chyme received from the ileum. From the cecum, the large intestine continues superiorly as the ascending colon. It travels up the right side of the abdominal cavity, from the right iliac fossa to the undersurface of the right lobe of the liver. Here it makes a sharp turn to the left, forming the right colic flexure, also known as the hepatic flexure. The ascending colon is typically retroperitoneal, meaning it lies behind the peritoneum and is fixed to the posterior abdominal wall. Its posterior surface is therefore in direct contact with muscles and fascia of the posterior abdominal wall and the right kidney. Its length is approximately 15 to 20 centimeters. Next is the transverse colon, the longest and most mobile part of the large intestine. It extends across the abdomen from the hepatic flexure on the right to the splenic flexure, also known as the left colic flexure on the left. The splenic flexure is situated higher and more posteriorly than the hepatic flexure, anchored by the phrenicocholic ligament. Unlike the ascending colon, the transverse colon is intraperitoneal. It is suspended from the posterior abdominal wall by a fold of peritoneum called the transverse mesocolon. This mesentery allows for considerable movement. Its length can vary significantly, often between 40 to 50 centimeters. The large intestine then continues as the descending colon, which travels inferiorly from the splenic flexure. It runs down the left side of the abdominal cavity to the pelvic brim, where it becomes the sigmoid colon. Like the ascending colon, the descending colon is typically retroperitoneal, fixed to the posterior abdominal wall. It is usually narrower and more deeply situated than the ascending colon. Following this is the S-shaped sigmoid colon, which is intraperitoneal and suspended by the sigmoid mesocolon. This allows for significant mobility. The sigmoid colon terminates at the rectum at the level of the S3 vertebra. The anatomical relations of the ascending colon are critical for understanding the potential spread of disease and for surgical approaches. Posteriorly, it lies against the iliacus muscle, the quadratus lumborum muscle, the transversus abdominis muscle, and the lower pole of the right kidney. The right ureter also descends posterior to it. Anteriorly and laterally, it is usually in contact with the anterior abdominal wall and coils of small intestine, specifically the ileum. The right paracolic gutter lies lateral to the ascending colon. These relationships are important in diagnosing conditions like paranephric abscesses or retroperitoneal tumors. The transverse colon, being intraperitoneal and mobile due to its mesocolon, has more variable relations. Superiorly, it is related to the greater curvature of the stomach, to which the greater omentum is attached, the gallbladder, and the inferior surface of the liver. Inferiorly, it drapes over coils of jejunum and ileum. Posteriorly, its mesocolon attaches it to the head and body of the pancreas, and the second part of the duodenum. Anteriorly, it is separated from the anterior abdominal wall by the greater omentum, which hangs down like an apron from the stomach and transverse colon. The descending colon, similar to the ascending colon, has important posterior relations due to its retroperitoneal position. It lies anterior to the lateral border of the left kidney, the quadratus lumborum muscle, the iliacus, and the psoas major muscle. The left ureter descends posterior to it. Medially, it is related to coils of jejunum. Laterally, it is in contact with the left side of the abdominal wall, with the left paracolic gutter situated between them. Understanding these relations is vital when considering pathologies affecting the left retroperitoneum or the descending colon itself. Its fixed position makes it less prone to volvulus than the sigmoid. Finally, the sigmoid colon, with its characteristic S-shape and sigmoid mesocolon, resides primarily within the pelvis, though its mobility means its exact position can vary. Posteriorly, it typically lies over the sacrum, the piriformis muscle, and branches of the sacral plexus. Anteriorly, in males, it relates to the urinary bladder. In females, it is related to the posterior surface of the uterus and the upper part of the vagina. Inferiorly, it is related to the rectum. Coils of small intestine can also be found surrounding parts of the sigmoid colon. Its mobility makes it prone to volvulus, a twisting that can obstruct the bowel. The paracolic gutters are clinically significant anatomical spaces within the peritoneal cavity. They are longitudinal depressions or channels found on the lateral aspects of the ascending and descending colon. Specifically, the right paracolic gutter is located between the ascending colon medially and the lateral abdominal wall, which is the peritoneum lining the transversus abdominis muscle laterally. Similarly, the left paracolic gutter lies between the descending colon medially and the lateral abdominal wall laterally. These gutters act as conduits, influencing the movement and collection of intraperitoneal fluid, pus, or malignant cells. The anatomical boundaries of these gutters are clearly defined. The medial boundary of the right paracolic gutter is the ascending colon and its associated cecum. Its lateral boundary is the peritoneum covering the right lateral abdominal wall. Superiorly, the right gutter is continuous with the subhepatic space, specifically the hepatorenal pouch or Morison's pouch, and can extend into the right subphrenic space. Inferiorly, it opens into the pelvic cavity. The left paracolic gutter is bounded medially by the descending colon and laterally by the left lateral abdominal wall. These boundaries guide fluid dynamics within the abdomen. The clinical importance of the paracolic gutters cannot be overstated. In cases of peritonitis, such as from a ruptured appendix or diverticulitis, infected fluid can track along these gutters. This can lead to the spread of infection to distant parts of the peritoneal cavity, like the subphrenic spaces or the pelvis. Surgeons often inspect and irrigate these gutters during abdominal operations to remove contaminants. Furthermore, in trauma situations, blood can accumulate here. Radiologists rely on identifying fluid collections in these gutters on CT scans or ultrasounds to diagnose various abdominal conditions. There are important differences in the communications of the right and left paracolic gutters. The right paracolic gutter is generally wider and more direct in its communication superiorly with the subhepatic and subphrenic spaces. This makes it a common pathway for the upward spread of pelvic or appendiceal infections. The left paracolic gutter, on the other hand, is partially obstructed superiorly by the phrenicocholic ligament. This ligament extends from the splenic flexure of the colon to the diaphragm, creating a shelf that can limit the free upward passage of fluid from the left gutter into the left subphrenic space. The arterial blood supply to the large intestine is robust and originates from two main sources, the superior mesenteric artery, or SMA, and the inferior mesenteric artery, or IMA. This dual supply reflects the embryological development of the gut, with the SMA supplying midgut derivatives and the IMA supplying hindgut derivatives. The transition point occurs approximately 2/3 of the way along the transverse colon. A thorough understanding of this vascular anatomy is essential for surgeons, particularly during colectomies, to ensure adequate blood supply to any remaining bowel segments. Ischemia can be a devastating complication if this supply is compromised. The superior mesenteric artery branches supply the cecum, appendix, ascending colon, and the proximal 2/3 of the transverse colon. The key branches involved are the ileocolic artery, which supplies the terminal ileum, caecum, appendix via the appendicular artery, and the proximal part of the ascending colon, the right colic artery, which supplies the main part of the ascending colon, and the middle colic artery, which supplies the hepatic flexure and the proximal 2/3 of the transverse colon. These arteries arise from the SMA and course within the mesentery or retroperitoneum to reach their target segments of the colon. The inferior mesenteric artery, or IMA, takes over the supply for the distal 1/3 of the transverse colon, the descending colon, the sigmoid colon, and the superior part of the rectum. Its main branches are the left colic artery, which supplies the distal transverse colon via its ascending branch and the descending colon via its descending branch. The sigmoid arteries, usually 2 to 4, which supply the sigmoid colon, and the superior rectal artery, which is the terminal continuation of the IMA and supplies the proximal rectum. These arteries also form anastomoses, ensuring collateral circulation. A critical component of the colonic arterial supply is the marginal artery of Drummond. This is a continuous arterial channel that runs along the mesenteric border or inner margin of the entire colon, from the cecum to the sigmoid colon. It is formed by a series of anastomoses between the terminal branches of the iliacolic, right colic, middle colic, left colic, and sigmoid arteries. From this marginal artery, short straight arteries called vasa recta arise to directly supply the colonic wall. The integrity of the marginal artery is vital, especially during surgery, as it provides collateral flow if one of the main colic arteries is ligated or compromised. The venous drainage of the large intestine largely mirrors its arterial supply, with veins accompanying the corresponding arteries. Ultimately, all venous blood from the large intestine, and indeed most of the gastrointestinal tract, drains into the hepatic portal system. This means the blood, rich in absorbed nutrients and potentially toxins, first passes through the liver for processing before reaching the systemic circulation. The main collecting veins are the superior mesenteric vein, or SMV, and the inferior mesenteric vein, or IMV. Understanding this pathway is crucial for appreciating drug metabolism and the spread of colorectal cancer. The superior mesenteric vein is responsible for draining the parts of the large intestine supplied by the superior mesenteric artery. This includes the cecum, ascending colon, and the proximal two-thirds of the transverse colon. The veins that contribute to the SMV are the iliacolic vein, the right colic vein, and the middle colic vein, each corresponding to their arterial counterparts. The SMV ascends within the mesentery, posterior to the neck of the pancreas, where it unites with the splenic vein to form the hepatic portal vein. This portal vein then enters the liver. The inferior mesenteric vein, or IMV, drains the region supplied by the inferior mesenteric artery, the distal one-third of the transverse colon, the descending colon, the sigmoid colon, and the superior part of the rectum. The tributaries of the IMV are the left colic vein, the sigmoid veins, and the superior rectal vein. The course of the IMV is somewhat variable. Typically, it ascends on the left of the IMA and passes posterior to the body of the pancreas to drain into the splenic vein. In some individuals, it may drain directly into the SMV or at the junction of the SMV and splenic vein. The clinical relevance of this venous drainage system is significant. For instance, in conditions causing portal hypertension such as liver cirrhosis, the increased pressure can lead to engorgement of these veins and the development of varices at sites of portosystemic anastomosis, although colonic varices are less common than esophageal ones. More critically, colorectal cancers often metastasize via the venous system. Cancer cells can enter the colic veins, travel through the portal system to the liver, leading to hepatic metastases, which are a common site of spread for these malignancies. The large intestine is under the sophisticated control of the autonomic nervous system, which modulates its motility, secretion, and blood flow. This system has two main divisions, the sympathetic and parasympathetic nervous systems. Additionally, the enteric nervous system, an intrinsic network of neurons within the gut wall, plays a crucial role in local reflex control. This intricate interplay ensures the coordinated movement of colonic contents and the regulation of absorption and secretion. Disruptions to this neural control can lead to significant bowel dysfunction. Sympathetic innervation to the large intestine generally acts to inhibit peristalsis, reduce secretions, and constrict blood vessels. The sympathetic fibers originate from the thoracic and upper lumbar spinal cord segments, T10 to L2. Preganglionic fibers travel via the thoracic and lumbar splanchnic nerves to synapse in prevertebral ganglia. These include the superior mesenteric ganglion, the inferior mesenteric ganglion, and the superior and inferior hypogastric plexuses. Postganglionic fibers then travel along the blood vessels or periarterial plexuses to reach the different parts of the colon. This system is activated during fight or flight responses. Parasympathetic innervation, in contrast, generally stimulates colonic motility or peristalsis and secretion, promoting digestion and defecation. The source of parasympathetic fibers differs depending on the embryological origin of the colonic segment. The cecum, ascending colon, and proximal two-thirds of the transverse colon, which are midgut derivatives, receive their parasympathetic supply from the vagus nerve, cranial nerve 10. The distal one-third of the transverse colon, descending colon, sigmoid colon, and rectum, which are hindgut derivatives, are innervated by pelvic splanchnic nerves, which arise from spinal cord segments S2, S3, and S4. These fibers synapse on ganglia within the colonic wall. The enteric nervous system, or ENS, is often referred to as the second brain. It consists of two major interconnected plexuses within the colonic wall, the myenteric plexus, or Auerbach's plexus, located between the circular and longitudinal muscle layers, and the submucosal plexus, or Meissner's plexus, found in the submucosa. The myenteric plexus primarily controls motility, while the submucosal plexus regulates secretion, absorption, and blood flow. The ENS can function independently, but is modulated by sympathetic and parasympathetic inputs. Conditions like Hirschsprung's disease, characterized by the absence of enteric ganglia in a segment of the colon, highlight the critical role of the ENS. Visceral pain fibers also travel with both sympathetic and parasympathetic nerves. The lymphatic drainage of the large intestine is an extensive network crucial for immune surveillance and the absorption of certain fats, though less so here than in the small intestine. More critically, from a clinical standpoint, it represents a primary route for the spread of colorectal cancer. The lymphatic vessels generally follow the course of the colonic arteries and veins, draining through a series of lymph node groups before reaching central collecting channels. Understanding this lymphatic map is vital for oncological staging and surgical planning, as the extent of lymph node involvement dictates prognosis and treatment strategies. Lymph from the colonic wall first drains into small epicolic lymph nodes, located directly on the surface of the colon or in the appendices epiploicae. From there, lymph flows to the paracolic lymph nodes, which are situated along the mesenteric border of the colon, adjacent to the marginal artery. The next station is the intermediate lymph nodes, found along the main colic arteries, which include the iliacolic, right colic, middle colic, left colic, and sigmoid arteries. Finally, lymph collects in the preterminal or principal lymph nodes, located at the origins of the superior and inferior mesenteric arteries near the aorta. Ultimately, lymph from these principal nodes drains into the preaortic lymph nodes, which surround the abdominal aorta. From the preaortic nodes, lymph passes into the cisterna chyli, a dilated sac at the inferior end of the thoracic duct. The thoracic duct then ascends through the thorax to empty into the venous system at the junction of the left internal jugular and subclavian veins. This complex pathway ensures that lymph, carrying antigens and immune cells, is filtered at multiple levels, allowing for a robust immune response to pathogens entering through the gut. The clinical significance of the large intestine's anatomy extends far beyond lymphatic drainage. Conditions such as diverticulosis and diverticulitis, which is inflammation of colonic pouches, inflammatory bowel disease, including Crohn's disease and ulcerative colitis, colorectal cancer, one of the most common cancers worldwide, colonic volvulus, which is twisting, and ischemic colitis, all directly relate to its structure, blood supply, and innervation. Accurate anatomical knowledge allows for precise diagnosis, effective surgical intervention, and appropriate medical management of these diverse and often serious conditions. To deepen your understanding of human anatomy and physiology, consider subscribing to the Joen Academy YouTube channel for more insightful content.